Good afternoon and welcome to today's program titled Women, Trauma, and Addiction. I'm Tom Valentino, Senior Editor of Addiction Professional. Today's program is sponsored by Foundations Recovery Network. Thank you to our sponsor and to our audience for giving us your time and attention today. Before we get started, we have a few details we'd like to go over. Each window on your screen can be moved by clicking and dragging, or enlarged and minimized by clicking the icons in the top right corner of each window. Please use the Q&A area to the right of the slides to submit a question at any time. If you cannot see this area, simply click the red Q&A button. To download a copy of the presentation, please click the link in the resources area in the lower left of your screen. If you have any technical issues during the program, please click the yellow Help button to troubleshoot the issue. A special note about CE credit. To receive credit for this program, you must click the green CE certificate widget at the conclusion of the program and complete the evaluation form. You must watch the webinar for at least 50 minutes in order to obtain a certificate. If you're watching the program in a group, please download the group submission form located in the resources list and follow the instructions. If you have any issues with this process, do not reach out to our sponsor as they will not be able to assist you in receiving a certificate. Please note, CE credit is not available for the archived webinar. It is only available for the live event. Finally, you can also tweet during the live webinar by clicking on the blue Twitter icon at the bottom of your screen. Simply click the Post and Authorize buttons to log into your Twitter account and begin sharing automatically at the event hashtag #APLiveWebinar. At this time, it's my pleasure to introduce our speaker, Marie Tueller. Marie is a clinical director at Canyon Crossing Recovery. She received her master's degree in counseling psychology from the University of Utah in 2007. She is a licensed practitioner in the state of Arizona and is currently working on her doctorate degree in counseling psychology. Marie began work in substance abuse and behavioral health treatment in 2001 and has had the privilege of providing a variety of behavioral health services over the years, including child and family therapy, adult and adolescent substance abuse counseling, inpatient clinical services and program development, community outreach and development of mentorship programs for at-risk youth and young adults, domestic violence counseling, coordinator for adolescent drug court intensive outpatient program, and grief support services. Thank you, Marie, for taking the time to speak with us today. And with that, the audience is yours.
Thank you. Thank you so much, and welcome. I'm really looking forward to talking to you all today about a topic that I'm really passionate about. As the clinical director for Women's Substance Use Treatment Center, my hope today is to share some of the things that I have observed as a professional to be especially effective when working with this population. When looking at substance use treatments for women, it's important to note that historically, treatment for addiction has typically been developed as singly focused interventions based on the needs of men. What we're discovering over the last couple of decades is that in order for women to have the best success rates possible, it's really important that we're acknowledging the realities of women's lives, which include the high prevalence of violence and other forms of abuse. A history of being abused and exposed to trauma certainly increases the likelihood that a woman will abuse alcohol and other drugs. And I want to begin today's lecture by discussing the relationship between trauma, post-traumatic stress disorder, and substance use, specifically among adult female populations. And then really looking at what the mental health implications are and specifically the treatment implications for women who are suffering from the co-occurring disorders of PTSD and substance use. And finally, looking at all of this through the context of a gender-responsive and trauma-informed treatment lens, and discussing specific treatment interventions that take into account the unique needs of women and what it really looks like to be receiving treatment for the co-occurring issues of trauma and substance use. First of all, when we look at women and trauma, it's important to note that there are some significant gender differences that we do see. Certainly women are not a homogeneous group, and men are clearly exposed to high rates of trauma. However, what we know is that half of all women in the United States will be exposed to at least one traumatic event in their lifetime. This fact continues to blow my mind. It is staggering, the frequency and prevalence of trauma and specifically violent types of abuse that women are exposed to. We do know that women are much more vulnerable than men to sexual assault and childhood sexual abuse than men. Approximately 18.3% of the entire female population in the United States, so 1 out of every 5 women in the United States have been raped at some point in their lifetime. Women also experience PTSD, so they meet criteria for the actual diagnosis of post-traumatic stress disorder at least 2 to 3 times the rate that men do. And so the lifetime estimates of post-traumatic stress disorder for women are about 9.7% in the United States, contrasted with 3.6% for men. And again, when we look at these gender differences, we do know that while a significant number of men are sexually abused as children, from ages 1 to 10, approximately 35 to 20% of sexually abused children are male. However, 65 to 80% are female. When we look at adult populations, victims of sexual abuse and sexual assault are almost always 100% female. We do know that the age of greatest risk for sexual assault for men is age 5, and for females it is age 14. So when we're working with adult female populations, the risk for trauma, specifically sexual trauma, is significantly greater when we're looking at female populations. Now, when we're looking at the relationship between trauma and substance use disorders, what we're seeing and what I've certainly noticed over the span of my career and my work in the substance use treatment field is that a vast majority of the clients that I work with have a history of some sort of trauma, often multiple forms of trauma, and this is certainly true for men and women. However, we do see significantly higher rates of trauma among female populations. We know that 80% of women seeking treatment for substance use disorders do report a lifetime history of sexual and/or physical assault. Women with co-occurring post-traumatic stress and substance use disorders also suffer from much higher rates of other comorbid disorders. And this can certainly create a much more complex treatment and more difficult prognosis. Common co-occurring mental health disorders that we often see are depression, anxiety, and other stress-related, mood-related disorders, in addition to borderline personality disorder, eating disorders, are some common comorbid issues that we do see. The rate of PTSD in the general population of women is approximately 11%. However, for women who are in treatment, we see those rates go up to about 30 to 59%. So when we're looking at individuals, and this is absolutely true for anyone suffering from addiction, but when we're addressing individuals seeking help for addiction and trauma, it is extremely difficult, if not impossible, to maintain any sort of sustainable abstinence because the trauma-based physiological responses, emotions, thought, can consistently trigger relapse potential. Trauma-related continuously stimulates the addiction compulsion. And this is why it is absolutely essential to bring in a trauma-informed approach when we're looking at the treatment of addiction. We see relapse rates just skyrocket when individuals are treated solely for substance use disorders and the trauma issues are left unaddressed. It's one of the most significant causes for relapse that I've seen over the course of my professional career. And we certainly need to look at more integrated modalities of treatment that blend both treating trauma and addiction simultaneously. So when we're looking at the specific process of trauma and why substance use disorders tend to be so much more prevalent among individuals who have been exposed to trauma, we all know that a traumatic event, can occur and many individuals are exposed to trauma. This does not mean that someone is going to develop these symptoms of post-traumatic stress disorder. However, the experience of living through a traumatic event certainly overwhelms the physical and psychological system. The individual experiences intense fear. And it's important to know that trauma is not simply limited to suffering through a violent or horrific event. It also includes witnessing a horrific event. In addition to the stigmatization that can occur as a result of suffering from post-traumatic stress disorder, stigmatization that occurs as a result of gender, race, poverty, and having other mental health issues in addition to addiction. The response is overwhelming feelings of fear, helplessness, and horror. And the symptoms that we all know of when we think about post-traumatic stress disorder, the re-experiencing of the traumatic event through nightmares, flashbacks, the extreme avoidant behaviors, isolation and estrangement from loved ones and community, the numbing of responsiveness, the hypervigilance, the exaggerated startle responses, all of those symptoms, those common responses to trauma that we see, develop an intense and hypervigilant response to stress in general. And so when these individuals experience those triggers and have those intense, painful, emotional reactions, the response, the fight, flight, or freeze response becomes activated. And naturally one wants to cope with that. One wants to either retreat or decrease the intensity of those responses. Substance use, for many, serves as a effective coping mechanism to manage the intensity of those responses. We also see isolation. We also see dissociation. Sometimes we see intense acting out behaviors such as aggression, violence, and rage. specifically, we are going to focus today more on the self-destructive responses to traumatic emotional states and triggers that create the fight, flight, or freeze responses. It's important when we're looking at trauma and substance use that we are viewing the substance use patterns as an adaptive coping response as opposed to a bad habit or something that an individual is doing to themselves. For the trauma survivor, substance use becomes a method of survival and managing otherwise intolerable symptoms. So again, when we're looking in the context of trauma, addiction is not simply a means to experience a euphoric state. It is a survival strategy. For many, it is the only way they know how to self-regulate and self-soothe. It is the only way to feel safe in a world that has no longer become safe. When we simply dismiss addictions, we can create a sense of shame and add to the already pervasive feelings of stigmatization that many, many women feel as a result of chronic mental illness, victim blaming, and suffering from addiction and PTSD. Substance use, again, is an effective way for many to numb those symptoms, to slow down that hyperreactivity, to manage impulsive responses, to distract from invasive, obsessive thoughts, to quiet intrusive memories, and often to facilitate complete dissociation. So when we look at the cyclical effects of trauma and substance use, when an individual is triggered as a result of experiencing a traumatic event and that stress response comes up, followed by those intense feelings of emotional despair and complete lack of safety, substance use becomes a familiar and repetitive coping skill. And over time, that reliance on substances decreases our ability to develop new coping skills. It decreases our ability to truly process through the psychological, emotional, and spiritual effects that the trauma has had on the individual. And continued use eventually leads to dependence. In addition to the lifestyle that often accompanies addiction and the inherent vulnerabilities that one has as a result of the impairment that's caused by use, can expose individuals to further trauma, which again reignites this entire cycle and reinforces the ongoing use of substances and the emotional upheaval and the ongoing decreased ability to heal and develop the necessary coping skills. So when we're looking at substance use and trauma, it's absolutely essential that we're integrating trauma services with addiction treatment services in order to reduce the risk of trauma-based relapse. I frequently hear arguments, both for and against the simultaneous treatment of trauma. Often individuals in the treatment profession may feel hesitant or even uncomfortable addressing trauma in early recovery due to the risk of stirring up past trauma and increasing the risk for relapse I hear professionals say that they don't want to trigger the client into experiencing cravings or strong compulsions to use. However, what we often see is women who used to be considered treatment failures because of relapse, we now recognize that they are trauma survivors who returned to alcohol and other drugs in order to medicate those constant triggers and the pain of living with that unaddressed trauma. The data we have now from integrated treatment shows significantly increased success rates. And we're seeing that trauma services combined with addiction treatment services vastly, vastly reduces the risk of trauma-based relapse. When the addiction is gone initially, it is very, very common to start to see the memories, the emotions, the thoughts that were being suppressed by the addiction to start to surface. It's impossible to heal the trauma while the addiction is active, and it's equally as impossible to ignore the trauma and only treat the addiction. We have to address the relationship between the trauma and the addictive behavior, while appreciating what the substance use did for the client at the time, and understanding that it was a survival and adaptive behavior. We have to understand how that behavior helped to medicate the traumatic activation and help the individual to develop coping skills and alternative behaviors to emotionally regulate and manage those symptoms. Stigma and shame that is associated with addiction, trauma, gender, mental illness also have to be addressed, as this can feed into the cycle of addiction and trauma activation. Addressing cultural, social, and systemic barriers that also increase risk for relapse is a key part of looking at gender-responsive treatment as well, which we'll talk about a little bit later in this lecture. So in addition to addressing the co-occurring nature of post-traumatic stress and substance use, we also have to be aware of the common issues that women with these co-occurring disorders face. We see a significantly higher rate of homelessness, unemployment, parenting and child custody related issues, domestic violence, criminal behavior, legal consequences, discrimination, financial difficulties, and many, many comorbid disorders in addition to chronic interpersonal violence. All of these issues have to be addressed on some level while the client is in treatment, in addition to helping to develop resources both in treatment and out of treatment in the client's community so that she can begin to overcome some of these barriers and start to view how some of these barriers played into the addictive patterns and the traumatic activation. More than anything, when I'm working with women who are trauma survivors, I see a pervasive sense of shame, internal shame, and shame that has also been internalized from a variety of external sources when we're looking not only at the perpetrators, but also cultural shame, societal shame, as a result of having addiction and having lived through all kinds of unspeakable traumas. We see women suffering with past and ongoing relationship issues. Many women experience significant barriers to getting help. fear of losing children, fear of losing a partner, fear of losing access to resources, financial resources, housing resources. Many suffer from physical health issues, parenting issues, lack of support and resources. And when we're looking at treatment issues, there tends to be a lack of services for women or a lack of gender-responsive services for women specifically. Treatment interventions that are not specifically finely tuned to address unique women's issues. There are often long waiting lists. I see many women seeking treatment, however, because of the lack of child care services or child care options, they are unable to receive the help that they desperately need and deserve. We see countless systemic issues, lack of clean and sober housing, and very poorly coordinated services where we're not seeing a truly comprehensive multidisciplinary approach. And so these are just some of the many issues and barriers that women typically face when seeking help for co-occurring trauma and substance use disorders. So trauma-informed care, as opposed to trauma-specific interventions, and this is really just a matter of language, but as professionals, it's important to know the difference. Trauma-informed care is really looking at the entire organizational structure of a treatment center or of a provider network. It is a framework that involves understanding, recognizing, and responding to the effects of all types of trauma. It emphasizes the physical, psychological, and emotional safety for both consumers and providers, and helps survivors rebuild a sense of control and empowerment. And the key words here are safety, control, and empowerment. And it is comprehensive and all-encompassing. We're really looking at a holistic approach here, and not just for the client, but for providers as well. We're looking at establishing a very collaborative relationship and network that is based on safety and an environment that communicates empowerment and support. It embraces a perspective that highlights adaptation over symptoms and a resilience over pathology. Trauma-informed care is really a strengths-based approach. Again, where we're viewing the client's attempts to cope with trauma, for example, substance use, as adaptive, as survival mechanisms that no longer work. At some point, those mechanisms allowed that individual to survive and cope. However, they became incredibly self-destructive, and the client or individual needs help now learning new ways to cope, adapt, and survive. And trauma-informed care provides a safe and nurturing environment for the individual to do that. Now, there are countless modalities and specific clinical interventions that we can talk about when looking at treating trauma. However, trauma-informed treatment and the principles that underlie that can be applied to any treatment modality, whether we're talking about DBT skills training, EMDR, somatic experiencing. Trauma-informed treatment is really a set of principles that guides the delivery of these services. So trauma-informed interventions generally recognize and adhere to the following. The survivors need to be respected, informed, connected, and above all else, hopeful regarding their own recovery. It focuses on the relationship between trauma and the symptoms of trauma, such as substance use, eating disorders, depression, anxiety, and a variety of other comorbid disorders. It educates and informs the individual of the relationship between all of the factors in her life and the context within which the trauma occurred and evolved. It focuses on collaborative relationships between survivors and professionals, between family, friends, community services and agencies, in a way that will empower the individual and the consumer to continue a lifelong process of recovery. So trauma-informed care is generally founded on a set of universal principles. Above all else, it's essential for organizations, professionals, and whatever capacity the professional serves in, that they seek to educate themselves in order to avoid any form of re-traumatization. It can be easy to reactivate an individual's trauma in ways that one is not even aware of. So first and foremost, education and promoting trauma awareness is the first step. Again, establishing safety, internal and external safety in the environment, beginning by stabilizing symptoms, especially the most distressing and destructive symptoms that the individual is experiencing. And we can do this in a variety of ways, just developing a concrete and consistent daily routine, transparent and open communication, supportive relationships, accountability, and again, a multidisciplinary approach through therapy, sometimes medication management, skills building, skills training through emotion regulation, coping skills, and our personal effectiveness. Trauma-informed principles really focus on connection, wholeness, support, collaboration, developing trust, peer support, empowerment, and encouraging the individual to use her voice. Trauma-informed principles also take into consideration the importance of culture, history, and gender-specific issues. We have to view trauma through a socio-cultural lens. Trauma does not occur in a vacuum, and it's important to consider the contextual nature within which the trauma occurred, because trauma healing also occurs within a contextual, socio-cultural environment. And again, through this process of learning and educating oneself, it's about integrating this knowledge into all policies and practices as we move towards a more integrated approach to trauma and substance use treatment. So this is just a simple visual here when we're looking at the contextual nature of trauma and the environmental factors that influence emotional, physical, and social healing. It's important to look at both the protective and negative factors in an individual's life when she's healing from trauma. Looking at just the biopsychosocial individual characteristics, the community-based characteristics, including family, friends, peers, social support networks, workplaces, neighborhoods, and moving out to the larger systems includes state and federal policies, economic and healthcare policies, social norms. All of these contexts influence a person's resiliency factors, her vulnerabilities to ongoing trauma symptoms and reactivation. Environments can have either a protective or negative effect on healing. And the key influences of culture, developmental characteristics, the type and nature of the trauma are all essential factors to be considered when we're taking a trauma-informed approach. the context of the trauma can significantly influence the initial and the sustained responses to trauma. So treatment needs to focus on the prevention, the intervention, and other treatment strategies in terms of providing hope and promoting recovery across all contexts of an individual's life. So we're targeting not just the individual, but her family, her relationships, community, and cultural systems. Again, just to re-stress the importance of viewing trauma and treatment through the lens of strength and resiliency, and validating the survivor in terms of her resilience is so important when we're looking at developing new coping behaviors. Understanding a symptom as an adaptation reduces a survivor's sense of guilt and shame, increases her self-esteem, and provides a guideline for developing new skills and resources to allow new and better adaptation to the current situation. So when we blend in a gender-responsive approach, and it truly is a complementary approach when we're looking at trauma-informed care, fortunately or unfortunately, because trauma is such a prevalent women's issue, gender responsiveness is just a natural outcropping of the trauma-informed approach. So gender responsiveness is about creating an environment, again, through looking at the entire organization, from the staff to program development, curriculum, content, and material, all of which reflects a deep understanding of the realities of the lives of women and girls, that addresses and responds to their strengths and unique challenges. So again, similar to trauma-informed care, gender responsiveness is not, we're not talking about a specific treatment intervention here. We're really talking about a set of core principles that can inform any treatment intervention that we can apply. And these principles, first and foremost, are acknowledging that gender is a significant factor. It makes a difference. Men and women tend to have very different experiences developmentally, psychologically, socially, and culturally. Acknowledging, validating, and normalizing those unique gendered experiences is an essential part of gender-responsive care. We also look, again, at creating an environment based on safety, respect, and dignity. Relationships, building in a very relationship-driven environment where policies, practices are relational and promote healthy connections to all aspects of an individual's life. When we go back to looking at the context within which an individual grows and develops, it's important to create holistic and healthy connections to all parts of those circles. And services, so we're addressing all issues from substance use to mental health issues, to behavioral issues, to trauma, through multidisciplinary, comprehensive, integrated services that consider cultural issues and issues that are unique to that individual. Again, socioeconomic status and recognizing the reality that women more often, generally speaking, than men tend to experience more socioeconomic hardships and require a great deal of support in terms of creating opportunities to improve and enhance those conditions. And this really creates significant opportunities for long-term sustainable recovery, and that's really what we're going for. And finally, community is that we're developing and establishing collaborative community services and working not just within sort of the island of just our practice or unique treatment program, but that we're networking and assisting those that we serve in developing their own networks and community-based resources. So specifically, in terms of incorporating a gender-responsive approach, for professionals or anyone that works with women who are trauma survivors, we have to really incorporate an integrative point of view. And that multidisciplinary approach, we're taking into consideration, all aspects of the behavior and the reality of that individual. And we're addressing the internal and the external obstacles that individual is faced with on a daily basis, looking at the gender-based barriers, whether that's stigmatization, cultural discrimination, shaming based on gender, trauma, mental illness, addiction, and we're really focusing and highlighting a strengths-based approach. We're recognizing and validating that culturally ascribed roles and gender expectations absolutely affect the societal attitudes towards women with addiction and mental illness. This is a huge barrier that I see again and again in working with this population, is the internalized shame that comes from cultural messages that countless women have internalized as a result of living with mental illness, living with addiction, living with trauma. We want to promote cultural competency specific to women. A fantastic example of this is relational cultural theory, which really focuses on understanding the unique characteristics of women's psychological development and their specific gender-based needs. This theory focuses on the importance of relationships and connection in the lives of women, and highlights the fact that for many women, relationships can serve as the venue for deep growth and healing, and that trauma is a huge source of disconnection. And this disconnection happens at a deep interpersonal and individual level, and it happens at the sociocultural level for many women as well. This happens through racism, sexism, heterosexism, classism, you name it. And the issues of dominance, privilege, are just two of many aspects of this relational cultural theory when we're viewing women's issues and trauma and substance use through a uniquely cultural lens. And so to further highlight this concept of healing through relationships, through connection, healing through gender responsiveness and viewing treatment through a uniquely trauma-informed lens, we really start to identify the characteristics and components of what successful treatment programs look like for women. We know that the chronic women's exposure to violence, abuse, and trauma has emerged as a critical factor in treatment settings for women. It is absolutely imperative that treatment services for women across the board become integrated. They become trauma-informed and begin viewing treatment modalities and interventions through a cultural, gender-informed lens. A gender responsive and trauma-informed program really can provide the safety, the nurturance, and the empowering environment that women need to recover and to heal. We're seeing more and more evidence that the adaptation of specific trauma-informed principles and gender-responsive principles are creating higher and higher success rates for women and longer, more sustainable recovery. There are countless resources, and towards the end of this presentation, I've included a list of resources that my hope is will be useful for those of you who are professionals working directly with trauma survivors, but also resources that are really useful for clients themselves in terms of peer support and self-directed healing. A powerful concept that I've selected from Judith Herman's book, Trauma and Recovery, really talks about healing through connection. And as a professional, but also as a woman in long-term recovery and a trauma survivor, I found this to be especially profound. She writes, traumatic events destroy the sustaining bonds between individual and community. Those who have survived learn that their sense of self, of worth, of humanity depends upon a feeling of connection with others. The solidarity of a group provides the strongest protection against terror and despair, and the strongest antidote to traumatic experience. Trauma isolates. The group recreates a sense of belonging. Trauma shames and stigmatizes. The group bears witness and affirms. Trauma degrades the victim. The group exalts her. Trauma dehumanizes the victim. The group restores her humanity. Repeatedly in the testimony of survivors, there comes a moment when a sense of connection is restored by another person's unaffected display of generosity. Something in herself that the victim believes to be irretrievably destroyed, faith, decency, courage, is reawakened by an example of common altruism. Mirrored in the actions of others, the survivor recognizes and reclaims a lost part of herself. At that moment, the survivor begins to rejoin the human commonality. I just want to thank you all for taking the time to join me today and allowing me again to discuss a topic and issues that I am extremely passionate about. And I am open to any questions following the presentation. So for now, I am going to turn it back over to Tom. And thank you again.
All right, thank you, Marie. That was very informative, terrific presentation. Before we get to the Q&A portion of our event today, and we have had quite a few questions come in already, I'd like to hand things over now to Leah Boone from Foundations for a few words from our sponsor.
Here at Foundations Recovery Network, our grassroots movement called Heroes in Recovery has a simple mission: to eliminate the social stigma that keeps addicted individuals from seeking help, to share stories of recovery for the purpose of encouragement and inspiration, and to create an engaged, sober community that empowers people to get involved, give back, and live healthy, active lives. Join us in this mission at our 6K race series at these locations across the country. As a thank you for your attendance today, please enjoy the discount code Webinar2016 to register for any future 6K events. Back to you, Tom.
All right. Thank you, Leah. As I had said, we had a number of questions come in already, and we are going to get to those now, but we'd also like to remind you that you can use the Q&A widget to the right of the slides to submit a question at any time. All right. First question we have here from the audience for you, Marie. If you had a client who worked through trauma but lived in a home where most of the trauma has occurred. What do you do in that situation to help the client?
That's a great question. So just to clarify, so the client is currently residing in the home where the trauma occurred. Is that correct?
I believe that is what the audience member was asking, yes.
So first of all, when we're talking about the issue of safety and looking at the trauma-informed response, they always recommend is establishing safety first and foremost, and as a provider to assess the risk level. So assessing, is the client currently at risk for being re-traumatized? Is she in physical danger in any way, shape, or form? And that's the first thing to really assess. And if so, to really assist the client and provide resources in order for her to find a safe place to go. And again, when we're looking at the possibility of reactivation, re-traumatization, certainly being exposed to an environment, individual trauma, cues, and triggers can significantly increase the possibility of re-traumatization and reactivation, which can complicate the healing process and make it very difficult. I, personally and professionally, often recommend that a client or individual, seek a safe place. Again, we know from literature, and then for me working with clients, that finding and establishing a safe environment is one of the key factors for creating the possibility for long-term recovery from trauma. So again, helping that client to find community resources, peer support resources to establish safety is going to give her the best chances possible in moving forward to some higher levels of therapeutic work. So I hope that answers your question.
Sure. All right. As we continue on with the Q&A, I want to remind everybody now is also a great time to consider filling out your CE certificate information, and you can do that by clicking the green CE widget on your screen. Another question we had that came in, how much, if at all, do you find family involvement necessary when addressing trauma? And go ahead.
Oh, sorry, was there more to the question?
No, that was it.
Oh, that's such a great question. And again, it really depends on the nature of the trauma. Certainly if family members were involved in the trauma or perpetrated the trauma, then that typically is not recommended due to all kinds of risk factors. However, if the family isn't a support system, that can be really essential later on down the line in the treatment process in terms of, again, building support, building connection when we're looking at that concept of connection, and also educating family members on the nature of trauma and the complexity of trauma to help reduce, the factor of stigmatization and shame and misunderstanding, which serves to really further alienate a lot of trauma survivors. There are family members seeing these symptoms and it's hypervigilance and reactivity, and without education and understanding of what that is and why that is, it can become incredibly frustrating and distressing to know how to cope with that as a loved one of a trauma survivor. So certainly educating and empowering the family alongside the is definitely a really effective intervention tactic. And I certainly, when families are open to participating, I definitely invite that, provided that there aren't any safety issues or increased risk of re-victimization. So that's a fantastic question. Thank you.
Sure. All right. How would you respond to a client who is comfortable with suppressing their trauma? The audience member here says she has a client who refuses to deal with it and occupies her mind and time with allegedly destructive things.
I think just about most, if not all, trauma survivors do go through a phase where they certainly prefer to repress the trauma and are very, very comfortable not talking about it. In fact, for many, that is essentially the primary goal, to repress, to not talk about it, to forget, and substance use and other very destructive behaviors essentially serve that purpose. And so, again, to approach that first and foremost, to normalize the behavior, again, not to necessarily encourage or feed into it, but to put it within a context. And certainly when I have clients that I'm working with who are very resistant to trauma work, to certainly just validate and acknowledge that that's one of their primary coping mechanisms. And when I encounter a client that I'm working with like that, I'll typically simply just start by resourcing, offering, coping skills and building coping skills without even really talking about the trauma or addressing it or pushing that too much. Again, because then we're risking we're risking re-traumatization, and again, more than ever, we want to establish that safe and supportive and collaborative relationship. And by doing that and by creating safety and resourcing and offering coping skills, what I find is eventually those walls start to break down, and that client begins to open up, sometimes not even knowing it, but that process starts to naturally happen. Usually not in my time, but it happens in the client's time, and that's the best timing possible. It rarely happens in my time, so it takes a lot of patience.
Okay. All right. We have a member of our audience who says she had experienced herself a very traumatic event, and she's also a recovering addict, and she wanted to ask, to what extent would you share your personal experiences with other women suffering PTSD and addiction?
Mm-hmm. Yeah, that's also a wonderful question. I am fairly open about my own personal recovery from addiction and my history of trauma, both childhood and adult trauma. Certainly, I don't share specific details. Again, that can often be very upsetting and distressing for people to hear. However, I do think it establishes a connection that is so valuable and allows individuals to experience a sense of hope that, healing and recovery is possible. Also, much of my work in terms of advocacy for trauma survivors is very public, and my personal story is actually published in the book Lean In by Sheryl Sandberg. So many people are aware of my personal story, and so I'm certainly very open about that. Certainly if there are current events in my life going on, those are things that I don't ever talk about with clients. I have a rule that, anything that I'm currently working through myself is off the table. But past issues and past events that, I have essentially resolved and become strengths for me and tools that I can use to support and empower my clients as well. So.
All right. I think that is going to be just about all the time we have for questions today. Certainly had quite a few more that came in, and we appreciate everybody participating today. A lot of great stuff. We do have some final instructions regarding CE credit, and again, should you have any issues with this process, please do not reach out to our sponsor, as they will not be able to assist you in receiving a certificate. To receive your certificate for this program, you must click the green Program Evaluation widget and complete the evaluation form and click Submit. For those who are watching in a group, as a reminder, please download the group submission guide and program evaluation located in the resources area and follow the instructions provided. For those of you who are watching from a mobile device or a tablet, you will need to email the help desk to receive a program evaluation and certificate for this program. Please note that CE credit is not available for the archives webinar. It is only available for the live event here today on October 25th, 2016. If you have any questions, please click the purple Contact Webinar Help Desk widget at the bottom of the screen. Also, if you enjoyed today's program, please join us on Tuesday, November 15th for our upcoming Addiction Professional Webinar sponsored by Foundations Recovery Network. The program, Process Addictions, the Role of Medication-Assisted Treatment, will be presented by Dr. Kirk Moberg. A link to register for this program is located in the resources box on the left side of your screen. I want to thank Marie Tueller once again for an excellent presentation today. I also like to thank Foundations Recovery Network for making today's program possible. Finally, a big thank you to our audience for participating today. We hope you'll join us in the future for another Addiction Professional webinar. This concludes today's presentation. Have a good day.